questions for the relevant panelists, please put them in the chat function to me, Colin McCann, and we will deal with the questions then at the end. Thank you very much. Emma Jane, over to you.
Thanks, Colin. So thank you for having me here today, everyone. My name is Emma, and I am a pharmacist who worked on the ISimpathy project, and I'm currently working in the Opt service. And my role as a senior pharmacist with the HSE is to deliver pharmacist reviews in general practice. So just to begin, what I'd like to do today is to review the concept of polypharmacy, and then what I'm going to do is move on to what we did in the ISimpathy project, what we're doing in Opt, and where we're going to go, where we hope this service goes in the future. So just to mention polypharmacy, there are lots of definitions of polypharmacy, but the most cited numerical definition of polypharmacy are those people taking 5 or more regular medicines daily. But we all know, like age, that's only a number, and we've all encountered patients doing really well on maybe 15 medicines and others who are unhappy taking just 3. The most important thing when it comes to the number of medicines that the person is taking is that each medicine is appropriate for the individual that's sitting in front of us at that moment in their life. And if any medicine is not appropriate for that patient, then we have inappropriate polypharmacy. And this not only represents one of the most pressing prescribing challenges, it can also increase the risk of avoidable harm to our patients. So there may be cumulative side effects, like Deirdre touched on earlier. There may be multiple medicines contributing to falls, for example. There will be an increase in hospital utilisation with the number of visits the patient needs to make to hospital, and indeed there may be avoidable hospital admissions. There may be therapeutic failure, whereby the patient actually fails to either intentionally or non-intentionally to actually take the medicines. There may be drug-drug interactions, drug-disease interactions, and indeed medicines waste as well. So Louisa touched on this earlier in the concepts of appropriate polypharmacy, and appropriate polypharmacy is actually defined as when all drugs are prescribed for the purpose of achieving specific therapeutic objectives, and importantly that has been agreed with our patient, that the therapeutic objectives are being achieved, or there's a reasonable chance that they will be in the future. So you might look to estimated life expectancy there, for example. That the therapy is optimized to minimize the risk of adverse drug reactions, and that the patient is actually motivated and able to take all of the medicines. And as Louisa said, the World Health Global Patient Safety Challenge, Medication Without Harm, includes the appropriate management of polypharmacy as a key priority area to reduce severe avoidable medication-related harm. And our target there is 50% over 5 years. And I suppose as an ISimpathy and Opt pharmacist, I feel really privileged to be able to contribute to that global challenge through our medicines review. When we look more closely here to polypharmacy here in the Republic of Ireland, we know that over 250,000 people are prescribed 10 or more regular medicines daily, and that might be known as hyperpolypharmacy or extreme polypharmacy. But 45% of people on 10 or more medicines are actually less than 65 years old, so it's not just limited to the older age cohort. Then whenever we look at PIP, or potentially inappropriate polypharmacy, it was seen to be prevalent in 51% of community-dwelling older adults and 70% of older adults resident in long-term care facilities. And then whenever we look to hospital admissions, 10% of emergency department admissions in people aged over 65 are associated with an adverse drug event, and a whopping 71% of them are potentially avoidable. So how do we reduce avoidable harm? And one of the ways that we suggest is through pharmacist reviews in general practice. And we are lucky enough to have done this through the ISimpathy project. And this was a 3-year EU-funded project that was operational from 2019 until March of this year. And it involved a partnership between Scottish Government, the HSE, MOIC and the Northern Trust in Northern Ireland. And the project was operational in primary and secondary care in Scotland, in secondary care in Northern Ireland, and here in the Republic of Ireland, the project was operational in CHO 1 and 8, where we had 5 pharmacists join 11 GP practices along the border counties. And what we did was deliver effective, comprehensive, person-centred, pharmacist-led polypharmacy medicines reviews. And we did that across 3 project jurisdictions, and we liaised with doctors, nurses, consultants to implement the agreed changes. Why did we do this? And our main aim was to enable those with multiple morbidities to live healthy and active lives. When we are conducting our ISimpathy medicines reviews, we adopted the Scottish approach, which is the 7 steps to appropriate polypharmacy. This gave us a structured approach to the medicines review. And what it does is gives you the opportunity to stop and think about medicines individually, but also medicines in combination. But the central point to these medicines reviews is that step 1, what matters to the patient. And it's really important to point out that ISimpathy represents shared decision making. So ISimpathy recognises that experts in healthcare include all of us as healthcare professionals, our policymakers, but patients are actually experts in their own care and their own need. And we want to empower them to become genuine partners in their care. So whenever we look to some of the results of the ISimpathy project here in the Republic of Ireland, we conducted over 2,500 medicines reviews with that number of patients. These were quite complex patients with an average of 6 comorbidities per patient. Our patients had an average of 12.2 medicines pre-review and 11 medicines post-review. And it's really important to point out that optimizing prescribing does not simply mean de-prescribing. It might actually mean adding a medicine in order to improve the outcomes for our patients. There was an average of 11 interventions per patient. This might be starting a medicine, stopping a medicine, increasing a dose, decreasing a dose, an education session, or indeed a referral to another healthcare professional. And when we look at our economic analysis, and I will touch on this in a little bit more detail in a moment, there was a saving of €185 per review. And we are currently working with the team in UCC to undertake an in-depth analysis of our Republic of Ireland data, and we hope to have some reports published soon. When we look at some safety and quality parameters of conducting the ISimpathy style medicines reviews in the Republic of Ireland, we did a small scale study at the start of the project, and we looked at potentially inappropriate prescribing, and we applied the STOP criteria. And of those identified, 75% of STOP criteria were addressed through ISimpathy medicines review. And then whenever we looked at potentially inappropriate omission and the application of the START criteria, of those identified, 80% were addressed through ISimpathy medicines review. And then in the application of the polypharmacy indicators, and these are included in the Scottish polypharmacy guidance, and these are medicines or combinations of medicines that are associated with potentially serious adverse outcomes. We can see some of them listed here in this table. So there might be falls, bleeding, kidney injury, or brain injury. And all of these are often and almost always associated with an admission to hospital. These were identified in 74% of reviews, and 69% of those were resolved through ISimpathy medicines review. I suppose it's important to point out that of those that weren't resolved, it is possible that it wasn't appropriate for that individual patient for that polypharmacy indicator to be resolved, but it's important to explore through a medicines review. If we look then to our results here in the Republic of Ireland, in contrast to our colleagues in Northern Ireland and Scotland, and our ISimpathy evaluation report will be published in the coming weeks. And if we look to the prevalence of those polypharmacy indicators here in the Republic of Ireland, we can see that they were prevalent in 42.2% of medicines reviews versus our colleagues in Northern Ireland and Scotland, where we have 4.6 and 9.4% prevalence. And then if we look to our pre-review PCMAI, or Patient-Centred Medicines Appropriateness Index, which is a score of inappropriate medicines, in the Republic of Ireland, it was more than double those in ISimpathy partner countries. And our reviews in Ireland achieved the largest reduction in PCMAI as well. And it's worth pointing out that we, as pharmacists in the Republic of Ireland, were the only group without independent prescribing rights. So I suppose these figures demonstrate the urgent need to address the risks associated with polypharmacy here in the Republic of Ireland, and the strong evidence that this model delivers substantial benefits and effectiveness far exceeding some alternatives. I mentioned earlier that the patient-centeredness of ISimpathy was the key component of our reviews. So we wanted to capture our patient experience throughout the project. And ISimpathy reviews are highly acceptable to our patients. There was a really high uptake of medicines review and an openness to changing medicines with that shared decision-making process. And that is in contrast to models that are reported in Irish and international studies. Phone reviews have been really acceptable to patients, even when we were in a position to offer face-to-face reviews after COVID-19 restrictions were lifted. And I suppose this reduces the need for pharmacist clinic time and also facilitates the spread of this service if we can work via VPN access to the GP practice. So the very positive feedback from our patients was captured formally through our patient-reported outcome measures, or our PROMs. And patients reported a 90% improved understanding, 63% reported a reduction in side effects. There was an improvement in the ability to engage with their activities of daily living, and an improvement in their adherence to their medicines as well. We captured some quotes from our patients as well. So these are a number of quotes that we captured. And one patient said, "The pains in my legs used to limit my walking distance, but this improved after my medicines review. Dad's mood and appetite are much better since his medication review." One patient said, "My mouth is less dry and my bowels have improved." And another patient said, "There was a definite improvement in my constipation and shortness of breath. I had no idea that changing my tablets could help with these things." So I mentioned already that we aren't independent prescribers here in the Republic of Ireland as pharmacists. So it was important that we worked in partnership with our GPs and the practices that we were involved in. And we captured the GP experience as well through the project. And the model has been embraced by GPs, and there's unanimous support among the project GPs for continuation and spread. So the GPs have reported that for their patients, there's positive effects on patient safety, quality of life, satisfaction, understanding, adherence, and the quality of care delivered. But interestingly, GPs have noted a positive effect on their own job satisfaction, knowledge, and understanding. There's a high level of acceptance of the pharmacist recommendation from our medicines reviews, and that reflects the GP confidence in the pharmacist and our integration into the practice. And this is in contrast to other models of medicines review, where acceptance and implementation of recommendations can be very low. Of course, we all know how time poor our GPs are, so time is a significant challenge when you're implementing any service into a GP practice. But with this model, the GP's workload is minimized as much as possible, because we pharmacists have already met with the patient, reviewed the records, the lab results, and contacted any other healthcare professionals such as secondary care before we discuss the report with our GP partners. We captured GP opinion through a survey throughout the project, but then some of the quotes we captured from GPs are that ISimpathy is one of the most impactful changes in general practice in 20 years. She makes our life so much simpler and so much safer. And one GP said, "I think having a clinical pharmacist associated with or attached to every practice in the country is going to be absolutely essential." So just coming back to the economic analysis again, and this model assesses the economic cost and benefits of comprehensive medicines reviews in the Republic of Ireland as part of the ISimpathy project. So our costs include hiring pharmacists and then the reimbursement of GPs for their time. They were paid $17.50 per review actioned. Our savings then included the direct savings as a result of stopping medicines that are no longer required, and then indirect savings of preventing a proportion of hospital stays due to potentially avoidable adverse drug reactions. And that results with a net saving of €185 per review. I think it's really important to point out that this €185 is calculated in the context of us working within a project capacity, and that we spent approximately 2 days per week in non-review activity. So additional substantial indirect savings have been calculated through our ISimpathy economic analysis with UCC, but we're demonstrating the minimum calculation here. But that report with UCC will hopefully be published in the coming weeks. So I mentioned that ISimpathy was completed in March of this year, and so from the 1st of April, there was a 9-month service extension for 4 pharmacists funded locally by CHO1 and CHO8. We're now known as the OPT service, or Optimizing Prescribing Together, and we continue to provide pharmacist-led medicines reviews in general practice following the ISimpathy approach. So that funding will be completed on the 31st of December. So what happens next? So there was a commitment outlined in the National Service Plan to roll out a programme to improve medication reconciliation or safety in the community programme, i.e. mainstreaming the ISimpathy model to address polypharmacy related risks and to deliver on the key commitments of the National Patient Safety Strategy. However, funding is not currently in place to meet that commitment. We know that the ISimpathy approach is aligned with Sláinte Care because we're delivering the right care in the right place, delivered at the right time and by the right team. And we've also looked at the possibilities of integrating this service into other services offered within the HSE already. So that might involve outpatient services or assessment hubs such as ICPOP and CDM. And we know that this service could integrate really well with our services already offered. Of course, this could only but be improved with the advancements in e-health and digital initiatives, and we know that there are advancements being made in that area within the HSE. So we've proposed a business case, and that involves introducing a dedicated primary care clinical pharmacist workforce to each health region to deliver medicines optimization services to patients who are at the highest risk of medicines related harm. So that might be adults who are prescribed 10 or more medicines, or those living in community or residential care facilities. This business case proposes a small core team working nationally to provide clinical governance and oversight and lead on engagement with all parties to manage the project. The core team will coordinate and develop the development of a multidisciplinary national guidance for managing polypharmacy and delivering medicines reviews by any healthcare professional in any setting and proactively optimizing medicines use. The idea behind this would be to introduce 48 pharmacists per year with the final target of having 3 pharmacists per community healthcare network. I suppose the risks, if this is not progressed, is that there would be a lack of medicines review service resulting in a failure to address the existing high levels of inappropriate medicines in patients with complex multimorbidity, medication-related harm, adverse outcomes, increased healthcare utilisation and expenditure on inappropriate medicines. There'll be a lack of guidance and training leading to further inappropriate medicines prescribing in all settings, and of course the migration of the skills, experience and personnel gained through ISimpathy and OPT. So just to summarise for you all today, the delivery of pharmacist-led medicines reviews in general practice is acceptable to patients, GPs and pharmacists. It effectively addresses quality and safety issues relating to medicines and promotes appropriate polypharmacy and of course patient empowerment, and its cost saving. So what I'd like to do now is just thank you all for your attention, and I welcome your questions during the question session. And I'm going to share some links in the chat now to bring you to some training resources that we've developed through the project. Some are available for pharmacists only, but will be available through HSE land shortly. Some that are available through the NHS resources that you should be able to access as HSE employees, and also a link to the Scottish Polypharmacy Guidance, and also to the National Frailty Education Programme that I and some of my colleagues are facilitators on, because we deliver an education programme on polypharmacy. Also, I work with the Sligo Leitrim division, and we'll be delivering a programme on the 29th of November as well. So I'll put all that in the chat. So thank you all very much.